My name's Brittany Sharpe Mccolomb. I own a business called Blossoming Bellies Holistic Birth Services. I'm based out of the New Jersey area in the United States. So for those that aren't super familiar, that's about 15 minutes over the bridge from Philadelphia, Pennsylvania. A lot of times people know Philadelphia. I teach a lot of different classes, education primarily focusing on perinatal advocacy, the labor process, having empowering birth experiences, and pelvic biomechanics, which is how we can utilize movement of the pelvic bones to decrease intervention rates during labor and birth. I also, as we mentioned, do a lot of work with perinatal professionals. I teach a lot of continuing education workshops focusing on labor physiology, focusing on pelvic biomechanics, supporting posterior babies, lots of workshops on that too. And I get to travel all over to do workshops for hospital groups, doula groups, midwifery practices, and so forth. I have been doing this work for almost 17 years. It'll be 17 years in July. I really started out because my first birth experience did not feel empowering, and I expected it to. I went into it feeling really confident and feeling really excited, but I didn't realize that the system in which we give birth was not really on the same page as me. I just kind of took for granted that people have been giving birth for thousands of years. This is something that I feel confident in, and it's been working really well for so long. And of course, they'll just support what I want in birth. And I came out of that experience feeling really unsupported and kind of diving deep into figuring out why I had an experience that didn't feel so good. And the more I learned about childbirth and also the system in which we give birth, the more fascinated I was. And the more I felt like people need to have this information. So I guess it was maybe 3, 4 months after my son was born, I started the certification process to become a childbirth educator and then to become a doula. And then by the time he was a year old, I had started teaching classes and attending births as a doula. And now he's almost 18 years old, which is crazy.
Oh my
And
gosh.
then, yeah, I know, I know. It's crazy.
Let's talk
And
about
yeah,
it,
and then and I have 3 other kids too. So I have my son who's almost 18, and then we have an 11-year-old, an 8-year-old, and a 2-year-old as well. And each of those births got better and better. And that's really my goal in everything that I do, is to help people not only feel confident in their bodies giving birth, but also feel confident in their advocacy skills, have an understanding of how to communicate with their providers, how to navigate the system in which they're birthing, so that they can come out of the experience feeling like they were respected and listened to and feeling like they did something totally amazing, rather than coming out of the birth experience feeling like something happened to them. So yeah, so that's kind of the backdrop for everything that I do, is really helping people as well as providers have a sense of how to create this empowering birth experience. And I think providers feel really good when they've helped to create an empowering birth experience. And sometimes when we talk about the maternity care system, we lump individual providers into it, but it's not necessarily an individual provider situation. It's the system. The system doesn't support providers, and it also doesn't really support the person giving birth. But I think we can do better to kind of work together and provide individualized care and hopefully help people have birthing experiences that feel really good.
Absolutely. Absolutely. Couldn't agree more.
Ladies, I am just popping in here quickly to let you know, if you are wanting a natural birth, you are not quite sure where to start in regards to your birth prep. What do I prioritize? Is it even going to affect my birth experience? Then I have the perfect free resource for you. It is our 14-day early pregnancy preparation guide, where we have exclusive pregnancy education by myself, yoga videos, pregnancy meditations, breath work for labor, and so much more. So if you want this guide, the link is in the show notes.
Amazing. So a really common thing I've had pop up amongst my mamas, I'm just going to read my little spiel that I've got here, because this has popped up a few times and it ties in with the next topic as well. So the early urge to push is what I'm going to be talking about here. So all for women listening to their bodies, right? Their bodies are telling them to push. And it's not a little nudge a lot of the time. It is a very full body, absolute need to push. And the early urge to push is diagnosed by having a cervix that isn't quite 10 centimeters yet. So what's your thoughts on the early urge to push? why do we get the early urge to push? Should we lean into it and should we satisfy that urge even though our cervix isn't dilated, or should we try to not as much as we can? And this always just pops into my mind because I see the side where people don't think that we should because we can create this swollen cervix, which I'm a little bit touch and go about anyways. But then at the same time, I just feel in birth, there is so much that we don't know. And we meddle in things that we don't understand. And I just think that in birth, everything happens for a reason. And it is all this kind of deep biological process of the body that we don't quite understand. And if the biology is telling the woman to have the early urge to push, there has to be some sort of reason behind that in my head on the other side of things. So what's your thought?
Oh my goodness, that is such a fantastic topic. So it's so interesting. So there is definitely, as you said, this belief that if somebody begins to push before they're fully dilated, that they're going to swell the cervix, or they're going to create some sort of adverse outcome for their baby or for them, exhaustion, whatever. But there is this very deep-seated belief that you cannot push until you're 10 centimeters. What's so interesting, and this is kind of a side note, although we might be able to explore this a little bit more too, that also means that in order to determine that somebody's 10 centimeters, if you fall into that belief system of we need to know you're 10 before you start to push, then that also means we need to do an internal exam to verify that you're 10. So I feel like that kind of like the internal exam and the reliance on internal exams kind of feeds into that as well. But that's another topic we could explore later. But it's so
Couldn't
interesting
agree more,
because
though.
it's a belief that we shouldn't push until we're 10 centimeters, but there's really not research to support that. The adverse outcomes that are often talked about, like swelling of the cervix or maternal exhaustion or increasing risk of distress in the babies, we don't actually see that in the research. Now, that being said, we don't have a whole lot of high quality research, but to also go along with what you were saying, like, why do we necessarily need research to show that something that is happening physiologically is okay? Do you know what I mean? Like
Yes.
the physiological process is the basic starting point. So maybe we need research to support any sort of interference with that. But if that's happening inadvertently, somebody is just their body is just pushing, why do we need research to then show that that's okay if that's what's happening automatically in their body? And I also would love to chat about something else that's related but not exactly that, but I think that it's so fascinating that we're like looking to stop this process in its tracks when the studies that we do have show that there's actually not an increase in adverse outcomes for the baby or the parent when somebody pushes before being fully dilated. Yet we still have this stronghold of like, you cannot push until you're 10, which again, like means that, okay, now we're going to keep doing internal exams to see if somebody is like any closer to 10 centimeters. And then we're potentially increasing risk there, especially if the bag of waters is broken. So yeah, really interesting. But that also kind of, I think maybe part of what you're getting at is like, well, what's happening in the body then, right? Like what's happening when somebody feels that early urge to push? And I don't know. Like you said, we don't have all the answers. There are some theories and there are some ideas about why somebody may be feeling an early urge to push. But I think there's a difference too between feeling an early urge to push and the body full on just pushing. So I think if we're talking about like that reflex of just like, oh my gosh, my body's pushing this baby out, that's a very different thing than somebody being like, I feel so much pressure. I really, really want to push. There's a difference between really wanting to push and the body just full on actively pushing.
Yes, couldn't agree more. That's so interesting you say that. I'm in a pondering state because this is something that I think about all the time. And I am honestly not overly surprised with your answer. Very much aligns with my thoughts. And same thing in the whole research, I've looked for this idea of a swollen cervix. Does a cervix actually swell? The concept of that just sounds really strange to me. But yeah, you're right. I couldn't find that. However, I love that you said the whole, why do we need research to back physiology? If anything, we need research to prove the intervention to the automatic response. Like, whose fucking idea was that?
Right?
Fascinating.
Oh my
Okay.
goodness.
So
Wait,
you're kind of
before you
yeah.
I was going to say, before you ask me another really good question, can I go off on a
Yeah,
tangent for a second about something
please.
related to prenatal education? Okay. So,
Yeah.
so I was saying that there's that difference between people feeling like they need to push versus like the body just taking over and pushing. And I think one of the things that I've found a lot just in teaching childbirth education to parents is that they understand that when they are ready to push, they're going to feel rectal pressure. Most people are told at some point by someone they know that have given birth that you feel it in your butt, like it's all in your butt when you're ready to push. But I think sometimes as soon as people start feeling it in their butts, they feel like, oh, maybe I'm ready to push. I must be ready to push. And in fact, usually when the cervix is about 6 centimeters dilated and the baby's at like a -2, -1 station, there's going to be some rectal pressure felt at the peak of contractions. And I think sometimes, and this is very anecdotal, theoretical, this is just my thoughts, but I think when people believe that rectal pressure equals pushing, they feel that rectal pressure around 6 centimeters just at the peak, and they're like, oh, I'm starting to feel it in my butt. And then that increases in intensity, and they're like 7 centimeters, 8 centimeters, and not having an overwhelming, like, my body's just doing it, but they're feeling so much pressure that they're like, I must be ready to push, not realizing that that pressure is going to get to the point where the body actually just takes over and pushes. So, one of the things I like to talk a lot about in birth class is that we will feel rectal pressure long before we're ready to push. And there's a big difference between feeling rectal pressure and the body taking over and pushing. So, trying to kind of help people understand that the sensations are going to intensify, it's going to progress as the baby gets lower, as the cervix opens more, and we have to be willing to like breathe through it and kind of embrace that sensation. And then when it does get to the point that the baby's head actually moves slightly out of the cervix, then the body's like, okay, now we got to get this baby out, and the uterus begins to bear down.
Yes, I hear exactly what you're saying. I think that's actually a really good point to communicate. Yeah, because it's like, because if they were to get, because sometimes I do get women who will get that really early urge to push, and it's this uncontrollable, like, oh, I can't stop it, I can't stop it, I can't stop it. But then they've had the vaginal exam and they're like 8 centimeters. You know, sometimes it's because they're posterior, and I know that that's a common thing in posterior babies, right? But then sometimes they're not necessarily, and I wonder whether that's more of a like a deflex type of head. Is that what you would think?
Yeah, yeah. And I think a lot with posterior babies, when the baby's head extends, that's going to put that pressure directly on the rectum and on the levator ani muscles that support the rectum. And then we're going to feel it way more in our butts than we would otherwise. And like, here's a theory, and I don't know the answer to this, but what if somebody did start pushing? Would that actually help the head to flex? I don't know. I wish we had research to like that kind of looked at that. Not even like research that like studied it in the sense of like intervening, but just like research that just observed like what happens if somebody wants to push with a potentially a posterior baby, that maybe that pressure was caused by the head extending, and then what if they begin to push? Does that downward force actually help the baby's head to flex? Who knows?
Yeah,
Maybe it does.
absolutely. Absolutely.
Yeah.
Yeah, fascinating. Because it's almost to the point where a mum will be coping really, really well in whichever labor that she's in, and she's getting this early urge to push, and she'll be wanting to fulfill that. And then, you know, they do a vaginal exam and she's 8 centimeters, and they're telling her to stop, telling her to stop. She can't stop, to the point that they say you have to get an epidural, and then she'll go get an epidural because she's told that if she doesn't, like, she's going to swell her cervix and her baby will never come out. And I just
Oh
think
my
that's
goodness.
really hectic. Like, that seems just such a, like, you're there, you're pushing, like, it's right freaking there. And then to get an
Yeah.
epidural at that point, because of that reason, it just, and when she's coping, like, she doesn't want it, she's getting it because
Mhm.
she's under the impression it's a medical reason. I just think it sounds so, pardon me, like, the word I want to say is dramatic.
Yeah.
Mm.
Yeah, I would totally agree with that. Yeah. And it becomes this like also kind of like you mentioned, like a chaotic experience and stressful, because now she's like, I really feel like I need to push. And providers are like, no, 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 you can't push. You'll swell the cervix. And then it's like, I want to push, but you can't push. And it's like, it just creates this really stressful environment, which isn't, I mean, we know the research supports stress not being good for labor or baby's oxygenation or blood pressure or any of that. So it creates this situation where then the epidural becomes like the savior because now it prevented the person from pushing too early. But what if like they needed to push, and what if they had done that? Like we don't know what would have happened in that scenario. Maybe their cervix would have just melted right out of the way.
Yeah. Yeah, yeah, yeah. Oh, it's fascinating stuff, isn't it? So when we
Yeah.
think about a swollen cervix, I'd love to know your thoughts about them. Do they even exist? And if so, why do we get them? And if so, what can we do about it? Can we push when they are there if our body is uncontrollably doing so, if our body is telling us to? What should we do if we
Yeah,
get told
so
we've got a swollen cervix?
that's a very good question. So I'm not a clinical provider, so some of that I feel like I'm not really in a position to be able to answer from that perspective at all, but I can definitely share, like, as a doula, as somebody who provides support, what I might do. I mean, I've been in a handful of scenarios with clients where their provider has told them that their cervix is swelling. Again, like, I don't do internal exams, so I don't have my own personal information to like back that or refute that or whatever. But in situations with clients where they've been told that there's some swelling, commonly what I've seen providers do is take a glove and put ice in there and hold it up against the cervix. I don't know. That feels really uncomfortable. It's uncomfortable to watch. It's also, uncomfortable, I think, for the person giving birth. I've also,
I've
in
never
some
heard of that before.
situations,
We
really,
definitely don't
that's
do
so
that here in Australia.
that's so fascinating because I've seen
Yeah.
that a handful of times. Yeah.
Oh my gosh, I find that. Yeah, well, it makes sense. Like you get a swollen wrist, chuck some ice on it, a swollen cervix.
Yeah, I'm just reporting what I've seen. I mean, I
Yeah,
don't
yeah.
know if that's I don't know where that trick came from, but yeah, so I've seen that a handful of times. I have definitely seen those births result in vaginal births. Is that because the ice worked with the swelling? I don't know. I have no idea. But I think that's an interesting way to handle it. I've also seen situations, now this is different, where there's been like a lip, a cervical lip, which we could also talk about the normalcy of that because that's, of course, there's going to be a lip until the cervix is totally gone. But
I'd
anyway,
love
I've
to
seen
talk about that when you're ready.
um, I've seen situations where providers attempt to like hold the lip back if there's that pushing urge. But again, what if we are finding that lip because we're doing these internal exams? I mean, if you think about it from a common sense standpoint, for everybody before their cervix is fully out of the way, there's going to be a lip, right? But are we finding that lip because we're doing an internal exam? Maybe because that person wanted to push. We're like, let's do an exam. Oh, there's a lip. I'll hold the lip out of the way while you push. But what if we just didn't know there was a lip and they just pushed and then their baby came out? Who knows? But yeah, but as a doula, what I will often do, I think a lot of times if there is talk about swelling of the cervix, which thankfully doesn't seem to happen all that often, the actual like diagnosis of a swollen cervix. But I, first of all, what I like to suggest are positions that may help to decrease swelling based on like where the pressure is. So if somebody's like maybe the posterior portion of the cervix is swollen, I might recommend some hands and knees positions. Or if the anterior part of the cervix is swollen, I might recommend like, how about we just recline for a little bit, even side lying, just to take some pressure off. That's usually what I would suggest in those situations, is just kind of changing position, maybe doing some slow rhythmical breath focused, like using eye contact as a focal point, just to maybe slow down some of that excessive force that might be happening on the cervix, assuming that the cervix is actually swollen and maybe the person is trying to push too, quote unquote, too soon. But changing position and definitely doing some like slow focused breath with like intentional eye contact or focal point, just to like slow down a little bit of what's happening there. But again, like in hundreds of births, I've really only seen a handful of times where there has been what the provider thought was truly a swollen cervix. There's been a lot of talk about swollen cervix in births that I've been at, but really I feel like I could probably count on one hand the number of times where providers actually said the cervix is swollen.
Yeah, interesting, isn't it?
Yeah. That's
Very
so
good.
funny about the ice thing. That
So
that you're like, we
funny.
don't do that in Australia.
Like literally, as soon as you said that, I was like, wow, that's so strange. Yeah, yeah, definitely. But isn't it funny? I feel the States definitely does things very different to us as we do to like Europeans, and it's everyone does things so differently, don't we?
Yeah.
Mm.
Oh yeah.
Women receiving epidurals for their own desires, absolutely fine, no dramas. What do you think? Because I see women get told a lot like we're suggesting this for medical reasons. What's your opinion on is there a medical reason to receive an epidural? And if so, what are they? When do
Yeah,
you think they
sure.
can actually be effective for a vaginal birth?
Yeah. I think there are definitely times so we're going to set aside people that want like just wanting an epidural, like that's its own thing. But if somebody's
Mhm.
actually being told there's a clinical reason for our suggestion for an epidural, our recommendation for an epidural. I mean, I think there are, based on the research, there are some things that epidurals can really help with that could potentially increase the likelihood of a vaginal birth. Like, for example, if somebody had high blood pressure, maybe the side effect of the epidural lowering the blood pressure could allow them to continue birthing vaginally if they still had like a long road in front of them. Whereas maybe a provider's concern about the high blood pressure may warrant, may not warrant, but may wind up leading to like an earlier recommendation for a C-section. So in that scenario, if we get the blood pressure into a quote unquote normal range, then maybe the provider is more comfortable with allowing, quote unquote, allowing more time for the labor process to unfold. So that could be a clinical reason, like that side effect of lowering blood pressure. I've seen situations where people are exhausted in labor. Usually it's been like a long build up, long prodromal labor, longer early labor. They're really, really exhausted. And the thought of finding those energy reserves to eventually push the baby out might be really overwhelming. And so in that situation, if an epidural can allow them to get a little bit of rest, that might be able to give them that energy that they need to then continue on and push their babies out. But I think we have to always weigh that with the fact that once somebody gets an epidural, usually they're not really as well supported in changing position. They are often encouraged, not even encouraged, strongly encouraged to give birth on their back, which we know has a whole host of other side effects like increasing risk of tearing and episiotomy and pelvic floor damage and decreased blood flow to the baby. So it's a situation where like the epidural allows the, maybe not the provider, but allows for a lot more restrictions potentially to be placed on the birth, which then may also increase the likelihood of other intervention or cesarean birth. So it's kind of, we really have to weigh out, I think, on an individual level, whether the clinical reason seems valid for that person or if it seems like it's more just a general one size fits all sort of recommendation. But clinical exhaustion and high blood pressure are two scenarios where I feel like those could be situations where the epidural could increase the likelihood of a vaginal birth. Interestingly, one of the situations that I hear a lot about and have seen with my clients is when somebody's planning a VBAC, so vaginal birth after cesarean, and they're told, well, in case there's a rupture, we need you to have an epidural so that we can immediately intervene. And that seems crazy to me because the epidural is going to, like we said, potentially restrict mobility, especially if a provider is not familiar with it. The epidural carries a whole host of side effects. And if we have somebody who doesn't want an epidural and is planning a VBAC, but is now being potentially coerced into getting an epidural because of a provider's fear of uterine rupture, which the likelihood of that is extremely low to begin with, that seems like a misuse of that epidural recommendation for sure. And I feel like that's a situation where it's commonly like, here's a clinical reason to get an epidural, but really the risks associated with an epidural in that scenario for someone who doesn't want them outweigh any potential benefit of getting the epidural to decrease rupture risk because the risk of rupture is so low anyway. So that's a situation that I feel like happens even more commonly, but is not a true clinical indication for an epidural.
Yeah, yeah, I agree. Same thing happens with twins, which I think
Mm-hmm.
VBAC is much less valid than the twin situation. And I don't know, but I feel like we create a lot of our own problems with the twins by giving the epidural in the first place. But then I do understand that when that second twin doesn't come out, it is very quick and urgent. And in that situation, having the epidural on board is amazing. But far out, yeah, like how many of the problems are we actually creating with that, with doing that?
Yeah.
That's a really tricky
Yeah.
situation. I've actually never seen a natural twin vaginal birth without an
Mm.
epidural.
Yeah. I'm trying to think. I don't think that I have either.
Okay.
It's
What's
crazy.
your thoughts on, yeah, crazy, on the thought of, I've heard of some midwives talk about epidurals used for medical reasons when baby's got a bit of a wonky head, like asynclitic or deflexed, when we've tried all the other movement things first. What's your thoughts on the validity of that?
Oh, that's such a great question. So, one thing that research does tell us is that babies that are posterior are less likely to rotate when somebody gets an epidural. So, a posterior baby is, according to the research that we have, generally speaking, they are more often than not going to rotate their way around the pelvis and then come out anterior. Only about, and I feel like we could uh, kind of break down this research a little bit more, but according to research, only about 5 to 8% of babies are actually born posterior, but there's some research that suggests a significant number of babies actually begin the labor process posterior. So we do know that if we were to kind of look at both of those sides of things, babies are likely to rotate their way around, even if they begin posterior. But we also know that when an epidural is in place, the baby is less likely to rotate through the mid pelvis as efficiently. But then we have the other side of things, which you just mentioned, like the idea that if a baby is in a funky position and we get an epidural, maybe it'll help the baby to have a vaginal birth, to be born vaginally. And I think there's probably some validity to that, but I think it depends on the reason why the baby is asynclitic or deflex. Like sometimes people are creating a lot of tension in their pelvic floor. Again, like that rectal pressure is happening. Sometimes if we're spending a lot of time in standing positions, our desire is to just like tighten up with that rectal pressure. And then we may be preventing the baby from having that space to kind of navigate their way down and out. And then also, if we are being restricted in our mobility, then we may not even be able to like kind of explore the different positions that might help create the space for the baby's head to shift. And then I think too, when people don't necessarily have the coping tools to like sink into their contractions and embrace their contractions, then a lot of times again like that tension and that lack of rhythmic movement may be kind of keeping the baby in a funky position, and then getting the epidural may allow their body to just relax enough that then the baby actually has a little more space, maybe a little more laxity in the pelvic floor muscles, which could potentially benefit that baby. But again, I think it's almost a dangerous thing to say that's a one size fits all approach, because what the research does tell us is that babies are less likely to rotate. So if we have a posterior baby with a deflexed head, then that baby may wind up getting kind of wedged in there even more if an epidural is in place, especially if that epidural is then restricting the positions and the amount of movement that the person's doing. So I think we
Mm.
could very, on a very like individual level and with really great support, we could definitely use an epidural in a situation like that as beneficial and still incorporate a lot of movement and changing of position and rocking of the peanut ball and things like that. But unfortunately, what usually winds up happening is someone's given an epidural and then the nurse is just checking in on them, like at least where we are, like once every hour or so. And there might be one position change that happens every hour, but that might not be enough, especially for a baby who has a kind of is positioned in a funky way in there.
Because I couldn't agree more, especially with posterior babies. They just need so much movement. However, if we do even have an anterior baby and their head deflex or wonky, and we've done so many different rotational positional things, we've done, rebozos and whatever, we've done maybe some other different sorts of movement, and babe's not just wiggling around. I'm under the impression sometimes it can be because of this hypertonic pelvic floor, which, maybe hasn't been dealt with in pregnancy, and that the epidural's purpose then can allow it to kind of relax a little bit and then allow baby
Yeah.
to move down. But as you say, like, how do we even pinpoint that that is the reason? And if that's the reason, then yeah, this risk outweigh benefits. But then there's all these other reasons where the risks don't outweigh the benefit, and being able to pinpoint that reason is really quite difficult.
Yeah, but I totally agree with you there too. Like if somebody has a really tight pelvic floor that hasn't been dealt with in pregnancy, then I mean, the hormones are in place to help soften everything up, but there's only so much that those hormones can do if somebody's lifestyle has kind of led them to having this really tight, tense pelvic floor. So in that situation, then sure, I think an epidural could be great. But like you also said, how do we know? How do we pinpoint that that's what's happening? And we kind of we can't really, unless that provider is also like a pelvic floor PT or something like that, they're probably not going to be able to necessarily know that that's happening. One of the things that I tell everybody in birth class is seeing a pelvic floor PT or OT in pregnancy is so important, because they'll get an individual assessment of their pelvic floor and then they'll get the exercises and the suggestions for ways to create that alignment and balance. And I feel like that's one of the huge factors that can impact people's births. It can impact the amount of discomfort discomfort that people are feeling. It can impact whether or not they're feeling back pain in labor. It can impact how easily the baby's able to move down and out. It can impact the baby's position. Like it's so, so huge. And there are things physiologically in place to help counteract tense pelvic floors. I mean, women have had tense pelvic floors forever. It's not just a recent thing, but and there are things like the relaxin that softens everything up, and the movement, the rhythmic movement that our bodies are like telling us to do to help manage these contractions, that's going to help. But if we can also get that support in pregnancy to deal with it before it's an issue in labor, I feel like that's even better. And I don't know what it's like in Australia with pelvic floor PT or OT, but in our area, like where I am around Philadelphia, it's definitely something that people are becoming so much more aware of. And I think it would be so fascinating to do like a 10-year study on the impact of people seeing a pelvic floor PT or OT in pregnancy and whether that improves birth outcomes. I would love to see research like that, but I don't think we have anything like that happening right now, at least not that I know of.
Yeah, yeah. No, it's definitely becoming a common thing, at least here on the Sunshine Coast, here in Australia, for sure as well, which is amazing. I'll actually link a pelvic floor physio that we use a lot at Natural Birth Co. She is amazing and she does do online as well. But it's, yeah, it took the words from my mouth. I feel like in pregnancy, you know, you can feel like you have to do so many things and it can feel like a lot of time and money, etc., with like, you know, acupuncture, chiro, osteo, physio, all the things. And they're all great. But I feel like if you can only choose one, pelvic floor physio is so important. I couldn't agree more. And as you say, wildly impactful to your vaginal birth experience. And you only need like 2 or 3 appointments, depending on, you know, the condition of the pelvic floor. But yeah, so amazing.
Mamas, are you not local to the Sunshine Coast but want to prepare yourself and your partner for a natural birth? We have our amazing new course called Birth Circle, which is run exclusively online. It is literally the most in-depth, integrative, supportive birth preparation service that we offer here at Natural Birth Co. If you want tangible steps, holistic practices, and expert support individualized for you to prepare your mind, body, and partner for a progressive birth, this is for you. The link is in the show notes for an August start, and there is only limited spots, so get in quick. If you're a little unsure and you want to have a free taster of the course, being our How to Cope with Pain in Labor module, then there is also a link for this freebie in the show notes.
And so amazing. And one of the things that I would add to that too, one of the benefits of seeing someone in pregnancy is that then they've established a relationship. So it's way easier to go back in postpartum and then get that support for healing. It's so much harder when you just had a baby to make appointments with somebody you've never seen before and something that's totally new. So when that relationship is started in pregnancy, then it's so much easier to just make that 6-week appointment or that, you know, that postpartum appointment. So yeah, it's such an underutilized resource, but becoming more and more popular. Yeah.
Thank goodness. Yeah, absolutely. So you kind of touched on it actually. So I feel like we're going to segue into this really easily, but we're talking about posterior labors and back labors, 2 different things I'm, you know, coming to realize over the last couple of years as well. So, yes, I did your amazing posterior baby and optimal positioning course and the myth of optimal positioning. And I talk about it all the time. It's such a awesome underpin of everything we do here at Natural Birth Co. in the birth workshop, the body balance workshop. It's so impactful to us. So I just love it. What I found, so sorry, I've gone off course, but so we talk about it and I teach my mamas helping babies rotate in the pelvis with position. I find though, after birth, mamas have a lot of back pain during labor. They are almost paralyzed in one position. So don't know necessarily posterior or not, but they're having a back labor and they're almost paralyzed in this one position, which is the least uncomfortable. And the thought of moving out of that position is just impossible for them. And for a lot of them, the positions I would have suggested that we've talked about in the course, they say like there was no chance of me absolutely getting into that position. What's your thoughts there? Like would just the woman intuitively moving her body and babe's head in a funky position or shape, or if she did the positions, would baby rotate a lot quicker and she just needs more support and reassurance to be in those difficult, I guess, more uncomfortable positions than the other?
Yeah, oh my gosh, that's such a good question. So I definitely think that people intuitively know how to move their bodies. But as you brought up, people also want to be in the position that is least uncomfortable. Like they want to choose the position that's most comfortable given the circumstances. So I think sometimes those two things are at odds. I think our intuition and our body telling us like you need to move, you need to like rhythmically rock your body, that can kind of be at odds with that desire to just like find the position that feels a little bit better and just stay there, because we know that if we move out of that position it could maybe feel worse. So there's like that little element of like fear or this feeling like I just can't do something else because it could be way worse than what I'm doing right now. So it's hard. I mean, it's hard. So for me as a doula, it's really, really hard when I have a client that like I feel like this could maybe help things, but they're really, really reluctant. And I found that one of the most important things is the prenatal education piece of it. So when I'm talking with clients at prenatal visits, and now I'm a doula, so I get like 2 hour visits with them. So we can cover all sorts of things different than like, a midwife would have. But one of the things that I like to talk about is what's happening with the posterior baby and what the research tells us posterior babies usually do. So with a posterior baby, commonly they're moving in with the back of their head along the right back of the person's body, and there can absolutely be exceptions. But according to the research that we have, this seems to be one of the most common posterior positions. And then they're going to rotate their way around the pelvis, and then most of them are going to come out anteriorly. But as they rotate around, they hit up against this sacral promontory, which
Yeah.
gets in the way here. And that sacral promontory can actually be moved out of the way by getting into semi reclined positions or positions where we tuck the pelvis in. But that means that there's a lot of pressure on the back. And so even if somebody's not having like excruciating back pain, sometimes when we get into the positions that support the baby's rotation, the back pain gets worse before it gets better. And I
Yeah.
like to tell people that in advance, like prenatally, if we're just discussing, here are some things I might suggest to you if it seems like the baby's posterior or baby's taken the long way around. And I let them know that the idea is that by helping the baby to rotate, we are we are creating a solution for that discomfort. Whereas if we just spend time in one position that feels like somewhat okay, and we're not moving and we're not shifting that space for the baby, it's like putting a band-aid on it. Like it's not going to get better. It's just like you're just kind of like dealing with it right now. But the
Yes.
goal would be to have the baby. And if we want to have the baby, let's help the baby rotate their way down and out. And so even if just for a short period of time, we can do just a series of 5 contractions in one of those semi-reclined positions or 5 contractions tucking the pelvis, then you can go back to that position that feels a little bit better for a little while. And then we'll come back into a position that feels a little bit worse, but is creating that space for the baby to make their way around. So I feel like talking about it prenatally is so important, because in the moment, if somebody's hearing all that for the first time, first of all, it's way too much for them to even process. But then also, like, someone's telling them that they should get into a position that feels worse, like, no, that's crazy.
Yes.
But if, right? But if their thinking brain in advance can process that information, then in the moment, if I say to them, can we try this position for a few contractions? They might be a little bit more open to it. And I always like to give people an out. Like, you don't have to do it for 3 hours. We're just going to do it for 5 contractions, and then we can do whatever you want again. And then maybe a few contractions later, let's go back to that for just another 5, and then we can do whatever you want again. So that's usually how I like to handle it. But I do feel like you're totally right that people find that spot where they're like, this is somewhat manageable, and then they just kind of stay there. But that's just helping them manage the moment. If the goal is to get the baby out, like we need to eventually kind of do something a little bit different. And one other thing that I really love to always add in as much as possible is rhythmic movement, because I feel like that helps with coping with the discomfort, more than just staying still. Even in a posterior tilt position, like even if I'm semi-reclined, if I can semi-recline like on the birth ball and rock side to side at the same time, that might
Yeah.
help me manage the contraction better than if I was just in a stagnant semi-reclined position.
So true. So true. That's very interesting. Love to hear that. Love to hear that. Yeah, I have had this woman before who had a posterior birth, and she was saying for like, what was it? It was something along the lines of 10 hours or something. She was just stuck in this like oh, you can't even see, but she's on her tippy toes, and then this one's
Oh,
extra high, and she was like kind of just like standing like this for so long, and it just,
oh,
yeah, she was like, it was the only thing I could do that would be comfortable. And you're right, it's like that recognizing what's uncomfortable and what's like, I
yeah.
guess, pathological, what's like closing the space of the pelvis, and that's why it's uncomfortable, and what's just increasing the pressure and increasing the
Yeah.
rotation, and that's what's making it uncomfortable, because one you want to lean away from, one you want to lean into.
Right,
Yeah.
right, absolutely. And it's interesting, like that position that you just brought up. Let me share something too. So I
Yeah.
have a yoga block here. So I'll do something like what you were just kind of showing, like one leg up a little bit. But one of the things that I find, just this is just a side note, it works really well with posterior babies, if especially if that position is something that she's automatically getting into. But doing this and then doing like some hip circles if possible. I mean, it might feel overwhelming for somebody. They might not feel like they can move through that, but adding in a little bit of hip circle with an asymmetrical position like that can sometimes help them stay in the position that's okay for them, but then also help work the baby out a little
So true. So true. And that's
bit.
where, pardon me, just so much support's needed, isn't it?
That's what it is. Yeah, and I mean the system just doesn't offer that, and it's not the fault of a provider, it's not the fault of a nurse. They're working with more than one person at the same time and they can't be in the room all the time. But if people could have doulas and doulas that are like well versed in movement and biomechanics, then it can make such a big difference. And even like simple things, if a nurse can even just share with a support person in the room, like encourage her to do this motion or encourage her to rock side to side with every contraction, encourage her to rhythmically move, even little things like that. I mean, a birth partner could totally be like supportive in encouraging that type of rhythmical movement. So even just little bits of like individualized support, even if the nurse just like shows the partner something real quick and then isn't able to be in the room again for an hour, like that could still make such a huge difference.
Okay, so I've got here actually, I learned recently that out of back pain labors, only 30% or so are because baby is actually posterior. What would the reason be that women are experiencing back pain without a posterior baby, and how do we manage that?
Yeah, that's a great question. So that's something that has come up a lot with conversations I've had recently too with physical therapists that I work with. It's so interesting. So theoretically, what could be causing the back discomfort for someone whose baby is not posterior? It could be tight uterosacral ligaments. I don't have a good model to show that, but the uterosacral ligaments are ligaments that connect the lower portion of the uterus to the sacrum. For some people's bodies, those ligaments actually connect to the iliac bones, not actually to the sacrum. That's just like a variation of normal. But I
Yeah.
also, of course, wonder, right? But here's the thing, like, could that possibly be contributing to discomfort in the back if those ligaments are attaching to the iliac bones or to the sacrum? Like, I don't know. Does the different attachment points create more or less back discomfort? Who knows? But having some tension or imbalance in the uterosacral ligaments is theoretically one of the reasons why people experience back discomfort. And also, it could be, again, theoretically, a reason why some babies may get into a position that's not super ideal for the space. Like maybe they get into a position where their head is tilted when that's not ideal for the space that's available, or they extend their head when that's not ideal for the space available. If the uterus is being kind of pulled in a funny way, that could totally impact how the baby is positioned. So, a couple of things that I like to suggest to people that they can do on their own in pregnancy, but also, of course, I always like to say that's why you see a pelvic floor PT or OT, because they're going to help diagnose that and then help you figure out ways that you can kind of create more of that balance. A couple of things that I love to just suggest to people is spending some time in an open knee chest position, rocking the bottom side to side in that position. The weight of the uterus is just going to hang a little bit, kind of pull slightly on those uterosacral ligaments. So that can be a really nice position to try. I also love
Sorry,
to
just
encourage
imagining,
people.
is that like
Yeah,
a,
I can show you.
is that an all fours? Thank you. Thank you.
Yeah, of course. So I would suggest doing it like wide-legged here so that there's space for the belly, coming
Yeah,
down onto the forearms, and then sticking the bottom up in the air. And then maybe
perfect.
like rocking front to back, or maybe
Mhm.
depending on how much mobility they have, a little bit of side to side. I
Mhm.
also really, really like to suggest this movement.
Yes,
I'm not so
love that.
sure. Yeah, I'm not so sure how much this is really working with the uterosacral ligaments, but it's creating a lot of mobility through the hips and the lower back. So I feel like
Yeah.
this is just such a nice movement that really addresses lots of the different areas of the pelvic floor and the lower back. So I recommend this to people too in pregnancy. And the thing is, like, this should feel really good. So if they do this a
Yeah.
little bit before they go to bed at night, or they're playing on the floor with a toddler and start doing this, I mean, it's just a really nice, simple thing that they can add into their day for greater comfort. And most people really love that knee chest position too.
Yeah.
That seems to be one that people find really comfortable. And it's like, I
Yeah.
like that position because it's very, very like easy to kind of get into and out of. It doesn't require a whole lot of support. You're just going from your hands down onto your forearms. It still allows for a little bit of that movement. So yeah, I really like both of those. And I tell people, like, if you like in the States, like pelvic floor PT, chiropractic care, it's usually not covered by insurance, or maybe a portion of it is. So for a lot of people, it's kind of financially out of reach. But I think there are a lot of things people can do that are free, that they can do at their house, even with just a few minutes of extra time per day. And mobility exercises, like the hip circles in all fours, the open knee chest with rocking. Those are really simple things that people can do that can create a little bit of that kind of relaxation and lengthening of the pelvic floor, and then combine it with some of that contracting in different areas. So yeah, trying to make things accessible to people, because it's hard to tell people, like, go see a pelvic floor PT, and yeah, it's going to cost you $300 out of pocket every time. Like, that's not going
Yeah.
to work for everybody.
So in the States, it's generally speaking, I know all doctors do things a bit different over there, but is your standard for a normal low risk woman to do auscultations every 30 minutes to monitor base? Is that the standard,
That's a
would you
great
say?
question. That's a great question. Usually it's like, if they've requested intermittent monitoring, it's going to be maybe 15 to 20 minutes out of every hour. So maybe 15 minutes on the monitor, 45 minutes off the monitor. But if they're low risk and they do not request intermittent monitoring, then they're probably going to be hooked up to the monitor continuously, unless they say something about not wanting that. The other option, though, which is more prevalent in birth centers in our area or with small midwifery practices, is to do intermittent monitoring with the handheld Doppler. And then it's going to be a lot more frequent. It's going to require somebody to be in the room more often. But then that person that's laboring can move as much as they need to. And then the provider is just going to, the nurse is going to just kind of figure out how to listen to the baby. But in your average hospital, if somebody who's low risk requests intermittent monitoring, it's going to be about 15 minutes on the monitor and then 45 minutes off the monitor.
And by monitor, do you mean the CTG, the one that stays on?
Yeah.
Wow. I find
Yeah.
that really surprising. That's the standard.
Yeah.
Because
Yeah.
here we do, like, unless there's a reason to, we'll do like the Dopplers that we'd use at antenatal appointments every 30 minutes. Just listen for a minute before and then the start of the contraction. Yeah, and that's it. But
Yeah,
would you look
yeah.
at
So
that?
that would be the norm at birth centers in our area,
Yeah.
and that would be the norm in home births in our area. But in a hospital setting, we're not going to use the Doppler unless it's a small midwifery practice that somebody's working with. Then there might be an opportunity to use the Doppler instead.
Amazing,
Yeah.
amazing. And with inductions over there, like here we do the mum would go in one afternoon, she'd get the balloon, the Foley's catheter balloon put in, go home the next day, come back, deflate the balloon, take it out, break the waters, and get a Synto drip. Is that the
hmm
same for you guys, or do you use the gel, or what do you guys do?
Well, first, your clients are going to go home with their Foley.
Yeah,
That doesn't happen here. I mean, we're moving slowly towards that. There has been some talk about that. I think that that's part of what a few hospitals in our area, probably because they're just so busy, that's kind of what they're wanting to do, is think about sending people home with the Foley. But it's not commonplace yet here, which is so interesting.
I'm
um,
feeling like we're
but
all hippie over here in Australia after this conversation. We're so alternative.
um, so funny. But it is common, just like you said, that combination of the Foley, but then often what's being paired with the Foley here, although again, like, it's going to vary so much from region to region in the United States, but also like even with from one hospital to the next in the same area. But commonly what I'm seeing is the Foley balloon paired with misoprostol. And the combination of those two happening in the hospital, and then breaking the bag of waters before someone is 6 centimeters, and administering Pitocin. We use Pitocin over here. So administering Pitocin, which then would be kind of the way that the contractions continue the rest of the time. Sometimes people will use Cervidil, which is like that little tea bag. It looks like a tea bag. It has some synthetic prostaglandins in it. But more commonly, it's a combination of the Foley and misoprostol, and then breaking the bag of waters, and then Pitocin. I always like to remind people that sometimes just the Foley and the miso sometimes puts you into labor, and like you can totally labor without needing anything else, even though it's far more common to wind up with that other additional things. But sometimes people are like, well, is it possible? Yes, it's totally possible to just have the Foley or to just have the miso or have the combination, and then your body takes over. But in reality, in the many, many, many inductions that I've seen, that's not the norm. Usually,
Yeah.
if without anything else, everything kind of fizzles out.
Yes, yes, yes. So you said then that you will break the waters before the woman gets to 6 centimeters. Does that mean, like, say you put the Foley's and the misoprostol in, and then you could even give it till like the next day, like maybe midday or something, before you would actually break the waters and give the Pitocin?
Yeah, so just to clarify, I don't break the waters.
No,
I know
sorry.
you're asking. I know that you know that. I just want to make sure that that's not being misconstrued
Fair.
by anybody listening. As a doula,
Cool.
I wouldn't break the bag of waters. But what I see, yeah, is that it could be like 24 hours after the process got started, or sometimes longer than that, sometimes 36 hours, 48 hours later. Usually what I see is that it's prior to 6 centimeters, like towards the end of early labor. Then it's like, okay, next step is going to be let's break the bag of waters. And I mean, it's not every provider. Many providers won't incorporate breaking the bag of waters into the induction. But if I had to say what is happening conventionally in a hospital setting, it seems that that's part of the process prior to, like, just prior to 6 centimeters.
That's my biggest little project at the moment, is not to rush the induction. And that's just see that constantly. It's such a rush. And, like, I think that's great, leaving it till later on before you break the waters and give Pitocin, because here we'll kind of even 1 or 2 centimeters, like, break the water and give the Synto. And then it's like just this big rush of increasing the Synto, like, let's get the contractions going. And I just think, yeah, it'd be so great if we could go through these inductions and not rush them. I think women would enjoy them a lot more, and we'd have a lot more successful, vaginal birth. Yeah, if we could not rush it. So I like that idea.
Yeah. Yeah, it's interesting. Like that's one of those things with the Arrive trial. Now there were lots of flaws with that trial, but one of the things that was so interesting is that possibly part of the reason why we saw vaginal births happening often were because there was a long amount of time given for these inductions. And although it sounds like what I'm saying is that there's a long time being given here, there's not really that. I mean, I feel like by the time somebody's 2 days into an induction in a hospital here, they've been poked and prodded so much that they're just like, I'm just gonna give in to whatever. Like if things aren't moving along efficiently, like I'll just give in. And I think that, yeah, one of the potential benefits to just like allowing that induction process to be slower is increasing the chances of a vaginal birth. But also, I think that there is that the flip side sometimes is that the parent gets so exhausted. Like the mom that's laboring is going to be exhausted after like a 4 or 5 day induction. So even when there's a provider that might be comfortable with that, sometimes it's like the person giving birth isn't okay with that. And then that's just a tough situation too. It's like, again,
And
like
fair call.
individualized care.
That's hard work.
Yeah, and it's hard work, and individualized care then is so so important, and individualized care that really focuses on making sure the person is supported and well fed, and hydrated, and like able to move their bodies, and just like there are ways to make a long induction feel more manageable, and I think sometimes we don't do a great job making that happen.
Oh, how fantastic. How fantastic. Is there anything else you wanted to add regarding the topics we just delved into? Because I know I just asked you a lot about a lot of random scattered things, but
I loved it. I
been
loved it. It was a nice little overview of lots of really wonderful things. I would just add, like, for anybody that's listening that is like pregnant or like, planning on becoming pregnant, I just think it's really important for people to know that they have autonomy. Like they can they can delay things, they can consent to anything, they can request things, they can refuse things. Like it's really important for people to know that just because, like, let's say it's been decided that they're going to move forward with an induction, maybe they're not comfortable with the conventional timeline of induction. Well, they have the right to say, like, actually, I want to slow this down, or I want to, I want to do the Cervidil instead of the miso. Now, is that always available? No, but there are options, and there's opportunity to have conversations with the provider. And I think when people start asking questions prenatally, that's even better, because then they have an understanding of what they might need to advocate for more or less strongly in labor. But remembering that they can talk, like they can have conversations with their provider. I think that's huge, because whether they choose to go along with everything that's suggested or not, or whatever choices they make, if they feel actively involved in the decision making, then they can come out of that experience feeling a lot more positive about it. When people feel like unsure about the decisions, or feel railroaded into things, or feel like they just had no say, I think that's when a lot of people wind up carrying like trauma in their birth that they then take with them into their postpartum. So regardless of what choices people are making or what situations they're in, just remembering, like, you can talk with your provider, you can ask about the options, you can ask about risk versus benefit, you can ask for more time to talk about it with your partner or your doula, and just like make a decision that you feel comfortable with. And I think a lot of people don't know that they even have that option of like asking questions or doing something different, or asking for time. So just for people to know
Yeah.
that, I think can be like very freeing, can be like, oh wow, like I can actually like be part of this process rather than just
Yeah.
have things happen to me.
Yes, yes, yes. I couldn't agree more. I couldn't agree more.
Yeah.
Oh, thank you so much, Britt. I am so happy for your time today. I really appreciate it. Would you like to tell people where they can access your courses and workshops and things like that? Because you do it for
Yeah,
both birth
yeah.
workers and parents, don't you? Yeah,
Yes, yes. And thank you so much for having me. This was so fun.
so fun.
So yeah, my my website is blossomingbelliesbirth.com, and you'll see on there's a section for parents, and that's going to have all of the classes and webinars and things like that. And I do offer a whole bunch of like free resources. We do a free webinar like every 4 months or so. So there's a whole bunch of archived free webinars on there. So that's always good for people to know, like you can get information and education even for free. And then I also have another section for professionals. So that's where you'll find the workshops and how to contact me to like host a workshop in your neighborhood, and all that sort of good stuff. So yeah, my website is full of information. So it's all on there. There's a bunch of self-paced courses too. And just like you were saying about your online course, like I was so excited to put together an online course, and then I realized like I have so much information that I want to put out there, and like way more than I could cover in like an in-person class that's like structured by like 2 hour time frames. So I just
Yes,
love that, like that ability to just put it all out there and be like, this is everything that you should know. So
yes.
yeah.
Well, that's exactly it. Like, I feel like I have all these separate things, and I'm like, I think all of them are needed in this, pregnant woman's life. But as you say, you can't
Yeah.
stick it into like one day or one weekend, and plus it's just too much to take in. So yeah, it's cool having an opportunity to give I say it's just everything and anything I have to say about pregnancy and birth, and it's just really
Hmm.
cool to just kind of like get it all out to the one person or couple.
Yeah.
So
Yeah, absolutely.
yeah,
I agree. I agree. Thank
yeah.
you so much. This has been so much fun.
Yes, you too. Have a good day.
Thanks, ladies. I really hope you enjoyed the podcast. One last thing quickly. If you are not pregnant, or you are and you're not quite ready to delve into the world of birth prep yet, you're going to want to jump into our Natural Birth Workers Advice, where we have gathered tangible advice from the best preconception, pregnancy, and birth professionals sent to your inbox every fortnight. From women's health physios to acupuncturists to chiros, all specializing in women's health. The link is in the show notes, and I'll see you in the next episode.